And now is the turn for Dr. Alfredo AAddeo, focus on new drugs in small cell lung cancer. Welcome, Alfredo.
Thank you very much, Charo and Luis and Elvis, for inviting me. And I'm really sorry for whoever is here, and thank you for staying until the very last. I'm going to try to make it interesting, hopefully. And thank you also, Alejandro, for setting up the stage for this interesting topic, because non-small cell lung cancer remains a very aggressive cancer, as you all know, so definitely we need to raise the bar. Here's my declaration of interest, and let's start straight away by talking about a possible novel target in small cell lung cancer. Has been known for a while as the AAddeo3 or delta-like protein 3. We know that it could play an important role in the inhibition ligand of the Notch signaling pathway, and we know it's quite often overexpressed on small cell lung cancer, pretty much in the vast majority of them. Therefore, it's an ideal target for a specific treatment or for targeted therapy. And over the years, it's been developed not just for small cell lung cancer, of course, but we're going to talk about these specific drugs later on for small cell lung cancer, like T-cell engager. They can directly bind the T cells with the CD3 receptor. I can also bind the cancer cells with the DDL3 in the specific case of small cell lung cancer. The first T-cell engager that's been developed, which is a bispecific T-cell engager, is tarlatamab, at least the first one that has been used in small cell lung cancer in clinical trial and also been approved already in the States by the FDA, not approved yet in Europe. And again, it's a double action of induce the proliferation and the activation of T cells, and also inducing the death of the cancer cells. How it's been developed? We have several studies. This is the first one. The Delphi-300 was the phase 1 study for patients with small cell lung cancer heavily pretreated. As you can see, about 107 patients were treated with a different dose. There was a dose escalation and a dose expansion up to 100 milligrams. And again, as I said, those patients were heavily pretreated with as a biomarker. If you want to use the DDL3 with immunohistochemistry, I don't think this is a great idea, given the fact it's overexpressed pretty much in all the patients. But perhaps it reinforced the idea that we should be using a specific T-cell engager against DDL3. And if you look at the response, I don't think the response rate was particularly high. It's about, let's say, 25% response rate. But what was, to me, really compelling was the duration of response, pretty much close to a year, which is something really important for us and quite relevant. Again, the median duration of response was quite long. And then the second step was the Delphi-301, as you can see, when again there was two different randomization, again patient heavily pretreated, small cell lung cancer, some of them with brain metastasis, and you see they were randomized to different dosing, the 10 milligram and the 100 milligram, and then there was the dose selection, which was the 10 milligram. And overall, all the patients that got treated, you can see here there was response rate slightly higher in the 10 milligram, about 40%. If you compare PFS and OS, I think pretty much similar with the two doses. And of course, what I should have said that if you give a higher dose, the toxicity is slightly higher. And we're going to talk about the specific toxicity that we have. I don't think we haven't encountered that yet, but it's something we have to become familiar, because there's going to be more and more drugs. They're going to have this specific toxicity. And this is progression-free survival and the overall survival with the update of the 10 milligram cohort for the Delphi-301. As you can see, progression-free survival of 4.3 months and overall survival of about 15 months. Again, you can see we're wondering, is a plateau there? Are we going to have a plateau? We have the impression, but it's a bit too early perhaps, but that's the impression we're having on the overall survival. Bear in mind, though, that just 1 out of 4 patient response, meaning 3 out of 4 progress. Again, this is the update about the 10 milligram. What is relevant is we always, when we have a progression after the first slide, we always talk about platinum-resistant and platinum-sensitive. And we know that in platinum-resistant, normally those patients have a poor prognosis. And if you look at the data of the Delphi-3001, so the tarlatamab, doesn't seem to be any difference between platinum-resistant or platinum-sensitive. The drug seems to be equally effective, which is a good news, particularly for those patients who progress very, very quickly after chemotherapy with platinum-based. How about side effects? This is something we have to become familiar. The higher the dose, of course, the more likely is to develop side effects. The side effects we have become familiar with is the cytokine release syndrome, which is something specifically, and I don't know what is anybody doing hematology here, but if you do CAR T-cell, every time I speak with hematologists, they always laugh at us and say that we panic a little bit too much because it's not that difficult to manage, it's not too high. but it's something we've never seen before. Therefore, we need to learn how to treat it. And also the ICANN, which is the neurological side effect, is something that we need to become familiar with. This is something that occurs quite often, and maybe with a low grade, but it's something we need to know how to manage, how to handle, as normally is, of course, depending on the grade. It could be just to hold the drug or give steroids. In some cases, if you have hypoxia, of course, oxygen. But it is something that, of course, depends on the grade, and very rarely is very severe. How about the development? Of course, tarlatamab is going to be developed in limited disease, and is being developed in extensive disease. You can see that we have at least two studies. One is we're waiting for readouts, it's the 304, so we see whether it's going to change second line. As you know, this has been tested in second line versus standard of care, which is either topotecan or lurbinectine. I don't know what treatment you use normally. I tend to stay away from topotecan. To be honest, it's not the drug that I love. Not that I love Taxotere, non-small cell lung cancer. Those seems to be difficult to beat, to be honest. And there's also the Delphi 305, which is in the maintenance setting. So we're also already trying to move it even before, and see whether in the maintenance setting could be also helpful. There's also a study that is going to start in first line with tarlatamab. Is going to be up to chemoimmunotherapy treatment compared to carbo and immunotherapy, which is standard of care at the moment. So there's a lot of development around tarlatamab. But this is not the only T-cell engager. There are others in development, as you can see. There are at least, I mentioned at least 3 in development. We have some data. Are those particularly different? There are some differences. The differences are, for instance, the affinity to the albumin and also the half-life, and maybe they might have an impact on reduced side effects and improved efficacy. And also is the timeline for the schedule of infusion. We know one of the issues we might have with tarlatamab, something that might come up later, is that you follow, it's weekly for 3 weeks and it's a bi-weekly. So it could be a bit challenging thinking to use this drug, for instance, for all the patients in first line for small cell lung cancer, if at some point that becomes standard of care. Can we expand a little bit the infusion and maybe give it every 3 weeks? So that's something also that might be relevant also for our patient. Having said that, some of the data about the obrixtamig, which is again a T engager, the rationale is pretty much the same. So it binds the T cells and the cancer cells. We have some preliminary data coming from the first human dose escalation of this drug, where they was tested not just in small cell lung cancer, but also in large cell neuroendocrine and in extrapulmonary neuroendocrine cancer, which I think it's something that we all have, and we don't know how to treat them. Very often we end up treating as we treat small cell lung cancer. Just again summarizing the characteristic of the patient, as you can see, patient of course were heavily pretreated, still quite fit, many lines of treatment, and if you look at the activity, particularly for the different dosing, if we focus on the more than 90 microgram per kg, you see this is where we see some responses. If you give a lower dose, as you can see on the table, there was no responses whatsoever, and overall response rate is not too far from what we've seen with tarlatamab, 25-30%. This is more or less what you get with T-cell engager. And again, specifically for small cell lung cancer, this one was for the whole group. This is specifically for small cell lung cancer at the dose of 90 microgram per kg. You can see again, response rate is not too far, not too different from what we have seen with tarlatamab, though there is definitely activity, and it's something quite promising. How about side effects? Again, I don't think we should not cross-compare, but again, the cytokine release syndrome remains the main side effects that they want to be aware of, and the one that we need to know how to treat. That's not the only one. Again, another TC engagers, the MK6070, quite similar with the rationale. Again, has been tested, as you can see in this phase 1 study, with patient, again, small cell lung cancer and neuroendocrine cancer at different dosing. And if we go then look particularly at the small cell lung cancer subgroup, we can see that we had about 56 patients. And again, some of them had also brain metastasis. Difficult to say because I don't have the information where they were completely untreated. I guess some of them might have brain metastasis already treated. And if we look at the response rate for the different dosing, the 1 milligram priming dose at 12 and 24, you can see response rate to me, even if a small group, 28 patients, quite good response rate of about 39%, so something to me quite interesting. How about the side effects? Again, unsurprisingly, I would say that the side effects are pretty much what you expect with this specific compound. So all these drugs that have some immune activity will come with CRS toxicity and with ICANS toxicity, and I think the grading and the occurrence will be pretty much similar to what we have seen with the tarlatamab. So this is for the T engager. How about the ADC? We've been talking about ADC a lot in non-small cell lung cancer. I got to be honest with you, so far I haven't been particularly impressed with the results we've seen with non-small cell lung cancer, but we're hoping to see something better, at least in small cell lung cancer. Here's just a at least to some of them. As you can see, they're not huge difference. The target is either the TROP2, as you would imagine, or the B7H3. And there are differences. The agent is pretty much similar, meaning they're all topoisomerase 1 inhibitor. What you also change is the DR. That might be either 4 or 8, depending on the drug. And I have some data. I'm not going to present all the data, but at least I'm going to be focusing on the ifinatamab deruxtecan, which is the first drug for which we have some data. As you can see, again, patient heavily pretreated, and we know that the patient had overexpressed, particularly small cell lung cancer B7H3. They seem to have a poor prognosis, and this is overexpressed quite often in small cell lung cancer, also justifiable and justified by the fact this is a very aggressive type of cancer. And again, mixed patient, some of them say 50-50 roughly. 50% of the patients were platinum resistant, 50% more or less were platinum sensitive. And again, quite a good number of patients had brain metastasis, 42% of them. They were randomized in 2 different arms, different dosing, 8 milligram and the 12 milligram per kg. And let's have a look at the response. You can see response rate slightly higher in the 12 milligram per kg, with about 44.8%, which is quite good, slightly different to what we've seen with the T-cell engagers. So higher response rate. The question is, are they durable? I don't think duration response is as good as the T engagers, I would expect. So it's about, as you can see, 4.2 months for the 12 milligram per kg and nearly 5 months, and 7.9 months for the lower dose. Now the dose that's been selected is the 12 milligram. That's been selected for the next study, which is DDED-Lung 02. And again, this is the progression-free survival, overall survival. Again, quite promising early data, so something to keep an eye on. The ADC seems to be effective in terms of response rate. Duration response, I think, are not particularly impressive in my opinion, but maybe be something we could combine at some point, and we're going to talk about it, I'm sure, with some form of immunotherapy. How about the intracranial activity? There is some intracranial activity, as you would expect. I would just go down and say 20 patients with brain mets that did not receive any previous radiotherapy. They have about 40% of intracranial response, which to me is quite good. And this is what more or less you would expect with some chemotherapy treatment. But those patients were heavily pretreated, so I think this is a good news. Another drug, antibody conjugate, is an ADC that we already know, the sacituzumab govitecan, again as an anti-TROP2. This has been tested in this basket trial, is the TROPiCS-03 basket trial, and again, heavily pretreated patient, the response rate was about 40%, as you can see, and the side effects are more or less what you expect with some form of chemotherapy treatment. If you look at the progression-free survival, again, not dissimilar to what we've seen before, with a good overall survival. Those patients are heavily pre-selected, so I wouldn't pay too much attention to the overall survival in this case. And the median duration of response is not dissimilar to what we've seen before, it's about 4.5 months duration of response. So, my conclusion, now this is what we have in first line, and what we have in second line, and to be honest, we all want to have more. Even immunotherapy in first line, let's be honest, the benefit has been minimal. Don't want to say marginal, but minimal for just a few patients, so we definitely need to raise the bar. And the good news is, and that's why I hope that you can see with me a little bit of light at the end of the tunnel, or at least I can give you and share some glimpse of hope, is that there are a lot of trials going on, and there's a lot of interest, and we're waiting for the readouts of the Lagoon and see whether we can have a positive study we've been active in. We're also waiting particularly for the tarlatamab for the Delphi 304, hoping that that would also change practice in Europe, because at the moment we do not have access to the drug, and this is really a pity. And then you see a lot of other studies in second line that might have an impact, and you go from ADC and other T-cell engager. And similarly, what I'm hoping that might happen is that we definitely raise the bar by having those new drugs. There is, of course, limitation. We can definitely do better, but finally we can see new drugs coming in small cell lung cancer. That remains a very difficult type of cancer to treat. There remains a cancer with a poor prognosis, but we can definitely do something more and something better. So the conclusion, and I think, and pretty much on time, one of the limitations we have with small cell lung cancer has been clearly highlighted by Alejandro, is we don't have any biomarker. I don't think whether we'll ever have any biomarker. And even if we are very optimistic about tarlatamab, I want to just stress out that yes, the patient who respond now might have durable responses, but it's 1 out of 4. I mean, the 3 out of 4 do not benefit. Why they don't benefit? Can we combine it with something else? Do we need to use ADC in first line instead of chemotherapy treatment? Do we need to differentiate the patient who get anti-PD-L1 and the patient who might get a T engager in first line? I don't know, but we definitely need to come up with smarter trial design. Otherwise, I think it's going to be very difficult to move things forward. And I really praise the colleague that have and the patient who accept to have a biopsy just to share the data with science and with the idea of helping other patients to understand what happened, because that's what we need to understand in the case of Dr. Latimer, to understand what we could do better, how we can select the patient. If we don't do that, it will be very difficult to raise the bar. Last but not least, we talk all the time about treatment. I think we should talk a lot more about prevention, because small cell lung cancer is strongly, heavily related to smoking, and that's something we need to push forward. So if we don't know smoke, there will be a lot less small cell lung cancer, and we would need a lot less drugs, and the overall survival would be, by definition, improved. Thank you very much for your attention.